So we still have 1 minute to go, and let's wait for all the people who are in time. Okay, I think it's exactly 3 p.m. and it's my great pleasure to welcome all of you to this seminar. We have now our 6th Immuno-Oncology Symposium here in Zurich. Unfortunately, it's a virtual event again, maybe the last time. And I have to say, I'm especially happy that we have splendid speakers. I'm very proud that the program is a world-class program. And I don't want to lose a lot of time because we want to listen to our excellent speakers. And we will start with Christian Blank. He is working at the Netherlands Cancer Institute in Amsterdam. He was educated in hematology and oncology. He had already built up an immuno-oncology group in Regensburg, Germany, before he joined the Netherlands Cancer Institute that is famous for their activities in the field of immuno-oncology. And actually, I can really say that he is a pioneer of neoadjuvant therapies. He is very enthusiastic about this and will us show what are the strengths of these therapies, and maybe during the discussions we also challenge him to find some weaknesses. So Christian, thank you so much for joining us, and we are looking forward to your presentation. The floor is yours. You can start to share your screen with us.
Yes. Thank you very much for the invitation, and I have to. Where's my presentation? This is not.
Yes, very good. I see your screen, and
no, it's not the right one.
It's not the right one.
I have too many open. This is the one that I wanted to share with you. So okay. So do you see it in full screen modus?
Yes.
Yeah.
Perfect.
Okay.
Perfect. Thank you so much.
Oh, okay. Thanks again for the invitation, and I will talk about the strengths and weaknesses of neoadjuvant immunotherapy, and I have made a dashed line through the weaknesses because I hope at the end you will be convinced that there are hardly any disadvantages in neoadjuvant therapies that we still thought some years ago. These are my disclosures. I have an advisory role to almost all important players in the melanoma field, research funding also, and also stock ownership. And I'm co-founder of Imagine BV, a company in the immunotherapy world. When we have a quick look first at what the concept or the conceptual arguments for neoadjuvant therapies are, is then we have to look into what is the standard therapy for these patients currently, and this is adjuvant therapy. So what you see in the cartoon in the upper row is that the surgeon removes the stage 3 disease, and then you start your adjuvant targeted or immunotherapy. We will focus today on immunotherapy. And what we know that micrometastases, which are the remainers, what we don't see, can hardly stimulate the immune cells, because we know micrometastases are less immunogenic than a macrometastasis with all this necrosis and danger signals that Polly Matzinger has learned us. So in that way, we've hypothesized that an adjuvant therapy will induce a few or weak immune response as compared to the lower row, the neoadjuvant therapy, the whole tumor with all these danger signals, but also with the whole variety still in, start the immune therapy. Then you get the broad immune response, you remove immune suppressive effects of the large tumor burden, and you have then a a very strong and broad immune response. And this has been proven by a small trial, the Essen trial. Still, I'm surprised that it is still the only trial that conceptually really compared this, and this was in melanoma done. You see, melanoma is often the lead, which comes later on in different cancers, where adjuvant and neoadjuvant therapy was compared, and I circled around where the PBMCs that we compared. So 6 weeks adjuvant therapy compared to 6 weeks neoadjuvant therapy. What you see in the right side is indeed that neoadjuvant therapy, exact the same, induces a broader expansion and a numerically higher expansion of tumor-resident T-cell clones in the periphery during the 6 weeks. So that's already a small trial showing that this concept, what we hypothesized, is right, not only in the mouse model shown later on by Michel Teng, but also in the humans. One more important thing before we look at the data, the clinical data of the neoadjuvant trials, is that you should keep in mind that in the macroscopic disease, we have with either targeted or immunotherapy adjuvant about 2 years relapse-free survival of 64–67%. But there's a big but. About 15 to 25% of the patients are screen failures, mostly due to early relapses post-surgery before these patients started at week 12 with their adjuvant therapy. And they were all not included into these trials. So at the end, if you compare a neoadjuvant trial, which is an intention to treat or an event-free survival measure, compared to the adjuvant therapy, which is a relapse-free survival, which selects out the worst patients that have these early relapses, then you need to lower your 2 years relapse-free survival of up to about 50% only when you want to compare neoadjuvant to adjuvant. Let's keep in mind 50% event-free survival at 2 years about. And now you see the first very encouraging data from the small trial where we had then with neoadjuvant clearly higher than adjuvant therapy, a relapse-free survival of 80 versus 60%, and an overall survival of 90 versus 70%, which is impressive. We know from the macroscopic melanoma that the 5 years overall survival is about 50%. And we still have not seen very convincing overall survival benefits from the adjuvant therapies. This could be also due to the subsequent therapies. But here I can tell you that these 90% patient that had an overall survival, nobody needed a subsequent systemic therapy. What is another advantage against adjuvant therapy is the fact that we know what we are doing. When you have the operation and you give the patients a 1 year treatment inducing the fatigue or endocrinopathies, you even don't know whether the patient has had a benefit from your therapy, because either it could have been relapsed anyway or not at all relapsed from the surgery only. And this is the majority of patients, what our adjuvant cohorts is. In a neoadjuvant setting, you see nicely that after 6 weeks of treatment, you know what you have done with your patient, because if you have a pathologic response, and that means that it is a complete response, 0% vital tumor near PCR, up to 10% vital tumor, or partial response, up to 50% vital tumor, then these patients have an excellent outcome, as compared to where you don't achieve a pathologic response, where you have 2/3 of the patients relapsing. This has led to another personalization that you also can't do in the adjuvant setting, namely that we tested in the subsequent Prado trial whether we can personalize the amount of surgery and the amount of adjuvant therapy. If you do neoadjuvant trials, you see the patients much earlier post-surgery than if in the adjuvant setting, and I'm sometimes pretty shocked how mutilating and how also insulting on the quality of life these large lymph node dissections can be for the patients. Yeah? also with long-term pain, lymphedema, seromas, what we've seen, infections, what we've seen in the opacity that I don't show now, but by what we presented. So therefore, we decided in the PRADO trial to say, can we reduce the amount of surgery in patients that have a good response? And to do that, you have to mark first one lymph node that you want to read out whether this is a good response if we want to omit a surgery. Have we done this? We placed a small magnetic marker into the largest lymph node. This is done by the interventional radiologist, then gave the neoadjuvant therapy and then removed only this one lymph node with a small, often outpatient surgery. In retrospect, Irene Reyes has also analyzed all patients from the opacin where all patients had a therapeutic lymph node dissection, compared the largest lymph node compared to the results in the whole lymph node bed. And you see that this index lymph node, how we call this, was representative for all responses in the whole lymph node bed. Here, the number 13, it even underestimated the response rate, but no underestimation concerning the depth of the response from the index node. So also overestimating. So in that way, we consider this approach very safe, and this was tested then in the PRADO trial, giving the, oops, why is it not going through further now?
I see your mouse, huh?
Yeah, but I can't go further. Redo. Presentation is not moving anymore.
It's frozen.
It's totally frozen. I have to stop sharing and start, sorry. So let's see. Yeah, now it goes on. So you see here we have given the neoadjuvant therapy, and then have at week 6 have done only this index node resection. And if the patients have had near PCR or PCR, what we also call major pathologic response, then we have not done any therapeutic lymph node dissection and also no adjuvant therapy. If the patient had a partial response, then we have treated as before with therapeutic lymph node dissection, no adjuvant therapy. And if the patient had no response, then we even escalated. So we gave a therapeutic lymph node dissection, adjuvant radiotherapy if possible, and gave adjuvant immunotherapy, anti-PD-1 for BRAF wild type, and adjuvant targeted therapy for BRAF mutated patients. And what you here see is now what the weakness also could be, is how many patients can undergo such planned treatment. Yeah, 99 patients started, and 6 patients had distant metastasis at week 6. You could speculate and hypothesize whether these patients are not only already stage 4 at the beginning and you demarked it, so you would do even its goods to the patients if they don't go for a surgery. This is what you can criticize. The 6 weeks waiting demarks definitively distant metastasis. Of the 6, still 4 underwent the index node resection because sometimes it's not clear whether it's really pseudo progression or a metastasis, and then you do the index node. And if this is a CR, for example, then the lesions that you sometimes see in the lung are definitely a pseudo progression. If there is a strong progression in the node, then you can also assume that maybe the lymph nodes in the lung interstitium are also metastasis. One other thing, 10 patients received only 1 cycle due to toxicity. And then for sure, patients that feel that they feel from the toxicity, or even say my lymph node is disappearing. Some patients even don't want a surgery at all. So at the end, you lose about 10% of patients from your intention to treat that then indeed underwent the index node resection. And now comes the nice thing, 60 of the 100, so 60% had this deep response and could omit the large surgery. Then we have 11 of a partial response. And then we have 21 coming here from this also that had a non-response. And then 17 started adjuvant therapy, 4 received not due to systemic toxicity from the neoadjuvant therapy. So you see, not all goes like how you want because of some patients' wishes, and some toxicity can intervene into your planned therapy. Nevertheless, I mentioned it already a little bit. We had a major pathologic response of 61% and a pathologic response of 72%. Still large, much better than the objective responses in the radiology. So I don't know yet how we can replace this small operation by a radiologic picture, because at the moment there's not good congruency. So less invasive than an index node, I don't see options at the moment. As expected, for sure, if you have only a small operation, then the toxicity is way better. You have only 40 as compared to 80 any grade toxicities, and beautifully no grade 3 toxicity at all in this group that had this small operation. So you can imagine that this translates very nicely in statistically significant improvement of quality of life of the patients, and also the long-term toxicity is way less. Interestingly, and this was also surprising to me, that the amount of surgery influences also the financial situation of the patients, which comes to all the cancer problems also in addition, and which is not nice, I think, if somebody has already problems and gets into financial troubles also. We are not the only ones that have worked on neoadjuvant. We have set up the International Melanoma Consortium together with MD Anderson and with Mia Sidney as foundings, but meanwhile there are 1,500 members. And the major goal is to streamline all the efforts that we make this comparable. And here you see from this paper from 2019, we have said how our standard therapy should be. There are still discussions. Do you need to give adjuvant therapy or not? You see in Netherlands, we tend to give no adjuvant therapy, while in the US trials and in Australia, there is given adjuvant therapy. 2 trials were targeted therapies, and 4 trials were immunotherapy trials. And what you nicely see now, what I've shown you, this is confirmed by the combination of these trials. If you achieve any response in immunotherapy, then you have this near flat line in the relapse-free survival, and only the non-responders have this strong chance of relapses. But this holds not true for targeted therapy, and we know this also from breast cancer, that this is not so strong the correlation like in immunotherapy, that only 80% remain relapse-free at 2 years if you have a pathologic CR upon targeted therapy. Even worse, the partial responders behave like the non-responders. Combination immunotherapy seems to be better than monotherapy. You see here the 2 years relapse-free survival is about 60% for the neoadjuvant anti-PD-1 therapy, and for the doublet with anti-CTLA-4, 80%. It's about 10% better than what you expect in the intention to treat for anti-PD-1 only, but still there's a 30% difference between adjuvant and neoadjuvant combination therapy. So I think we should work in the future on characterizing patients that could get away with anti-PD-1 only, because even if it remains at the end only 50%, this is even better tolerated than the combination therapy, and identify this 30% that should receive the combination therapy, and then find for the remaining 20% something different. There are two trials running now. The SWOG trial that compares pembrolizumab neoadjuvant followed by anti-PD-1 pembrolizumab adjuvant, and comparing this to neoadjuvant anti-PD-1. But as shown, I don't expect that this trial will be strongly positive without subgrouping the patients, because there will be maybe a maximum of 10% relapse-free survival at 2 years difference. So it could be that this trial will be underpowered. But the neoadjuvant trial, as I said, comparing neoadjuvant combo versus adjuvant anti-PD-1 has we expect a 30% absolute difference. So this will be strongly positive most likely. And we are recruiting now, started end of last year. And this is an international trial. And we hope that within the next 2.5 years, we will recruit the 420 patients. And then this will establish the neoadjuvant combination immunotherapy. Going a little bit further, we have also worked on, can we predict upfront the response based on baseline markers? And we found that in the combination of interferon signature and tumor mutation burden gives us a 100% pathologic response if you are positive for that, and only 40% if you're negative for both, and about 90% in between for one marker. And this translates very nicely in the event-free survival of 100% for the doublet high and only 50% for the low, and then in between at the plateauing at 80–90% for the monotherapies. That's very important to know. And we have developed now an algorithm which is challenging, because it's always easy if you have the whole cohort and you say this patient is a high and low if you compare this to all patients. But if you are now starting a trial where you have only the result in absolute number from one patient, then you have to allocate them to high and low. So you want to have a good quality control that is, and it needs to be fast. And we have now developed an algorithm that will be most likely developed further in collaboration with a company towards a companion diagnostic, that within 2 days we can allocate the patients to interferon signature high and low. And this was applied already in the DONIMI trial that we presented at ESMO, where we now gave de-escalated interferon signature high to even monotherapy, and gave escalated in the interferon signature low to a triple therapy of ipi/nivo plus HDAC inhibitor, and then giving in both arms also the doublet HDAC inhibitor plus anti-PD-1. What were the results? All presented at ESMO, and that's very interesting. If you are interferon signature high and if you get nivolumab, then you have 90% response rate pathologic. If you have the doublet, it doesn't add anything. I think it will be hard anyway to beat 90% if they confirm in larger cohorts. But if you are interferon signature low, then you are really in need, because then the doublet drops to 30%, and this is a little bit corrected by the triple therapy. It has also a big impact on the relapse-free survival. Interferon signature high, 100%, interferon signature low at the 80%. So if you are interferon signature high, you can be de-escalated most likely to monotherapy, and this will not impact your relapse-free survival. What we've seen also before in the INMC analysis, if you are a good responder, then also for the anti-PD-1 monotherapy, you will not relapse. Here I have some confidential data, and that is even stronger, and because you have more data. If you from interferon signature high patients, you see that nivo or nivo-ipi doesn't give a big difference. It's all for both 90%. So most likely in the future, we will give this population only anti-PD-1, which gives almost 0% grade 3 or higher toxicities. If you are low, then it's about 50% that you can achieve with ipi/nivo. So this is a population that is already a considerable good treatment option, but we want to split this in the future in 2 additional groups, one being benefiting from ipi/nivo and one needing possibly alternative or triple therapies. These are coming. You see here different schemes, and I've shown already that we might find the signatures for that. And this is all running in different centers. So in that way, we can expect that in the next years, we can do this personalization. The end, I would like to show quickly neoadjuvant therapies in other cancers, because it was in various cancers, the strengths and weaknesses. Here you see colorectal cancer, either MSI high or MSI stable. And for the MSI high or the microsatellite unstable tumors, there's excellent outcomes of almost all patients having a CR. If you see in the red upon the combination, but also interestingly for the stable tumors, you see some very deep responses and also to reduction of 30%. And you might question yourself, these patients that achieve near 100% pathological response, can we mark them either in a different way that we omit also in such patients an operation? Because I don't believe that the operation in these patients still adds something. Same holds true for bladder cancer. Impressive tumor regression of the primary tumor here, all published in Nature Medicine. Nature Medicine is meanwhile in neoadjuvant medicine journal supporting this initiative very early on. You see an excellent overall survival and relapse-free survival for high-risk stage 3 bladder cancer. And finally, I have also, this is, sorry, the title wrong, this is head and neck cancer, also published now from Matthias group. You see also very nicely that we, in about more than 1/3 of the patients, we achieved deep responses with near 100% response, and these patients have no tumor progression. And you want to ask yourself whether these patients still need these mutilating operations that you see in the head and neck field when you have this treated with squamous cell carcinoma in the head and neck region. With that, I would like to end, and I'm more than happy to discuss the weaknesses, but except for some demarking of possible stage 4 disease, which I don't see a disadvantage that you prevent these patients to having a large operation. I see at the moment not many disadvantages if you see the long-term outcome of these patients. Thank you very much for your attention.
Thank you so much, Christian. So very exciting field, and it's also challenging to see how this is also affecting our other disease entities. And I'm surprised to see such high response rates in a neoadjuvant setting, for example, for renal cell cancer or for head and neck cancer. So I think this is by far higher than the responses seen for metastatic disease. Huh? Exactly. Okay, I see. Yeah, maybe you want to comment on this, and then we can go into the questions that are already in our chat.
Yeah. So for colorectal MSI high, I think it's impressive, and with now Miriam is extending this to 100 patients, and I wonder how we want to still randomized trial when you have 100% response rate in 100 patients. Yeah. What I expect for that. So this is also what we have to discuss in the future, how we want to bring treatments that are so strong to the field without stepping back for the patients and then comparing it. Yeah, that's a challenge in the future. But let's go to the questions indeed here.
See, the first question is from Lucy about HDAC inhibitors.
Yes. The HDAC inhibitor, yeah, I don't know whether it's a reduction. I would be more careful. I would say it's the same or doesn't add anything. It's 10 patients per arm, and whether you have 8 or 9 responses, I don't know. It could be that the HDAC inhibition reduces some immune activation, or due to the toxicity, and I have not discussed as much. We had a lot of skin toxicity and had to start early, also steroids, that this was the problem, that we have not given in the perfect dosing scheme for neoadjuvant. You know, the problem often is neoadjuvant that you need less, and you start off, you make your phase 1 trials in late stage patients with a very strong immune suppressed immune system, and then you go to the neoadjuvant with that dosing. So I tell the companies always, you have to do 2 phase 1 trials, one for the late stage and one for the neoadjuvant. But for money reasons, this is not done. And sometimes we saw more toxicity from domatinostat than what we've seen in stage 4 before.
Mm-hmm. Okay, thank you, Christian. Then there is a question from Florencia Dimitriou. And she's asking about the pathways and non-path responses, and whether we have any other biomarkers that can help. I think this is a very good question. So
I don't see it. Where is this? Yeah, here. Thank you. It seems the signal difference between patients that would have path response and no response. Yes. Could you please comment on the majority of the pathologic criteria to access response? Yeah, I think the pathological responses at the moment, the absolute best marker for the outcome. If you have, you will see the Prado data at ESCO. They are even more impressive for the long-term and the distance metastasis-free survival from the responders. And the baseline markers, yeah, we are working on that. We have found this TMB and the interferon signature, but it's still not a 0 versus 100%. It's 40 versus 100%. So we have to find some additional markers there in that way. We try to now understand these unexpected responders that have a low tumor mutation burden and a low interferon signature, so not an effector phase and a low visibility and still have response. Mm-hmm. There's a beautiful work coming now from Stephanie Spranger, where she worked on neoantigens from membranous molecules versus cytosolic molecules. And it seems that if you have more mutations in the membranous proteins, that then the outcome upon checkpoint inhibitor is way worse than if cytosolic neoantigens. So that's the question now, is there a different processing of these molecules, or is it maybe that the membranous molecules interfere with the interaction of the immune cells with the tumor? We have some ideas that we want to address this. We're using HLA high and low, HLA positive and negative, A2 positive negative patients using the predicted neoantigens in Prado. So this will come. So we are working on that to understand these last 40%. Yes. Yeah.
Just a question from my side. Can you use PET-CT to distinguish?
That's very hard because we see very many circuit-like reactions. I'm always reluctant to put the PET-CT in, because then you would have many unexperienced clinicians will say this is progression. Yeah, we have this already with CT scans, with this intervisceral lymph nodes that people think that this is progressive. I think with a PET scan, this would be more even worse. And so therefore, I'm pretty reluctant to do this. Yeah. Mm-hmm. But if you would get PD-1 PETs or things like other PET scans than FDG PETs, I could imagine that this could work here.
Okay, there is another question on colorectal cancer and the role of irradiation therapy. Can you see this? Could you perhaps comment on the benefit of radiotherapy to immunotherapy in the setting of an organ-preserving approach for colorectal cancer?
Yeah, on the radiotherapy, I can't comment, but on the immunotherapy, these patients in the neoadjuvant setting that had this 100% response were MSI high tumors, so this subgroup. This is the disclaimer. But I believe that these patients do not need an operation anymore. This is the only thing, the problem is how you know, in melanoma, it's easy that you do an index node resection and then, but how do you prove a pathologic response in a primary colorectal cancer? Will we have a PET scan for a tumor marker, or do we have multiple biopsies? So this is something what we need to find out in the future. But I believe that this will be also a therapy modality that will come here.
So there are many additional questions, but unfortunately, I think we have to move on. And maybe, Christian, you can have a look.
I can answer them in the chat. So I will stay and answer them in the chat here.
This would be fantastic if you can deal with the questions. Thank you so much.
Yeah.
And now it's my to be given by Professor Selma Ugurel, who is now affiliated with Essen again in Germany. She has started her career in the Saarland and has done a lot of research together with the German Cancer Center. Her work is excellent. She has gained a lot of prizes and acknowledgement, and she is very experienced in several fields of dermato-oncology. And today we will hear about Merkel cell carcinoma. And I think this is a very interesting disease because at least most of the Merkel cell carcinomas are driven by a viral agent. And we know that viruses are good targets for immunotherapy. So I think it's a paradigm for future immunotherapeutic approaches. Selma, thank you so much for joining us for this meeting here.
Yes, thank you, Reinhard, for the friendly invitation to this nice meeting. Even if it's only virtual, it's nice to see you all again. And yeah, I try to share my slides. Do you see them now?
Yes.
Perfect.
Very
yes,
good.
It's on Merkel cell carcinoma. I have a short introduction to this. It's a highly malignant skin cancer. The malignant grade is higher than, for example, in melanoma. And in the clinical appearance, we see a fast-growing tumor of a red color, just typically located in the sun-exposed areas of the skin. And it's characterized by early metastasis and by a high mortality. And we have two known etiopathogenic factors. One is exposure to UV radiation, and one is the so-called Merkel cell polyoma virus, which was just mentioned by Reinhard Dummer. And what is this Merkel cell polyoma virus? Some of you might not know. This special virus, it's an oncovirus and was first detected in Merkel cell carcinoma cells as a viral DNA, which was clonally integrated into the host genome. This was in 2008, the first description. And we know that here in Northern Europe, we have this clonally integrated virus DNA present in about 70 to 80% of Merkel cell carcinomas. So here in Germany, it's more 80%, maybe in Switzerland, this is because of the sun, this is a little bit lower. And we also know that most of the virus-positive MCC cell lines are essentially dependent on virally encoded proteins, and these are called the small and large T antigens. Here you can see again the two etiopathogenic pathways of Merkel cell carcinoma, the virus, the sunlight pathway. It's interesting to know that, for example, in Australia, where there's much more sun, this is like 50 to 50%. So, yeah, as Reinhard already said, Merkel cell carcinoma therefore is a prototype for the investigation of virus-associated cancers. And this was already done extensively also here by our own group, especially by Jürgen Becker, who's also here in Essen. And here you can see, for example, an analysis of Merkel cell carcinoma cell lines. And these blue ones are the virus-negative cell lines. The red ones are the virus-positive cell lines. And as you can see, the virus-negative cell lines have a much higher mutational burden. And if you look in detail to the mutational signature, you can see that these virus negative cell lines have a typically UV-induced mutational signature, and the virus positive cell lines do not. So this is an interesting fact. Now, some clinical features. What about the treatment of patients with first diagnosis of Merkel cell carcinoma, patients with primary tumors with no evidence of metastasis? Here we do surgical excision of the primary with wide safety margins. Then sentinel lymph node biopsy is recommended for all sizes of primaries. So this is also different from melanoma. And then we have adjuvant radiation as a recommendation, radiation of the primary site, also in all primary tumor sizes. Then if the sentinel node is positive, which is the case in a high rate of patients, approximately in 30% of patients, a complete lymph node dissection is recommended or radiation of the involved lymph node basin. Both options are equally applicable. And if we have clinically detectable lymph node metastasis, so macrometastasis of the lymph node basin, the regional lymph node basin, then a complete lymph node dissection is recommended, and thereafter an adjuvant radiation of the lymph node basin can be done, but this is not generally recommended, so at least in the German guidelines. We know that the prognosis of Merkel cell carcinomas patients is extremely poor, or we have better to say was extremely poor prior to the introduction of checkpoint inhibitors. And this is from 2017, a review. And here you can see what is more or less the original biology of the tumor before we could treat them with checkpoint inhibitors. And here you can see that after the first metastasis, so from stage 3 or higher, patients had a 5-year survival rate of less than 40%. So this is extremely poor and poorer than, for example, in melanoma. What do we have for adjuvant treatment for these patients? I already told you we have adjuvant radiotherapy. Chemotherapy is not recommended. There are no data showing any benefit of adjuvant chemo treatment of Merkel cell carcinoma patients. And then for immunotherapy, which is of course an interesting treatment for these virus positive tumors, here trials are still ongoing, and we don't have a recommendation for treatment for the adjuvant treatment of Merkel cell carcinoma patients. This is our largest adjuvant treatment trial, which was done in Germany and the Netherlands, the so-called ADMEC-O trial. And here we had a 2-to-1 randomization. Patients were treated with nivolumab or observation only. Here, 120 patients are already enrolled, have already been treated, or are still under treatment, and the results are awaited at this year's ESMO. And we are very eagerly awaiting these data, because if they were positive, this would be the first adjuvant treatment which could be recommendable for Merkel cell carcinoma patients. So what do we have for patients with advanced metastatic disease, which is no longer resectable? We have again radiation, because these tumors have a very high radiosensitivity, high response rate to radiation, but of course radiation is applicable for single to few lesions only. Then we have chemotherapy, which was for long years the treatment of choice for non-operable metastatic Merkel cell carcinoma patients, because MCC has a very high chemosensitivity. Response rates are high, 50 to 60%, but the responses are of very short duration only. So only 3 months in the first line, only 2 months in second line, and there are more or less no durable responses. So this is not a very good treatment option. Targeted treatment is also not recommendable because there's no common driver mutations known for Merkel cell carcinoma. So there's no kind of BRAF mutation for Merkel cell carcinoma. But immunotherapy, this is the treatment of choice because of the high immunogenicity of these tumors. And we also have an EMA approval for a PD-L1 inhibitor, avelumab, since 2017. I will show you some data now leading to this approval. First, the rationale. Why is Merkel cell carcinoma such a nice target for immunotherapy? Because of both pathogenetic pathways, the viral pathway leading to these viral and very foreign proteins, the small and large T antigen, which are then presented by the tumor cells and leading to a high immunogenicity of these tumor cells. And the other pathway, of course, is the UV-induced pathway, which also leads to accumulation of mutations, presentation of a high number of neoantigens, and hereby also to a high immunogenicity. So this is the perfect target for immunotherapy with immune checkpoint inhibitors. And this was the very first clinical trial with pembrolizumab. And as a first-line treatment in patients with Merkel cell carcinoma. And here you can see there was a very nice response rate. Objective response rate was 56%. So just remember that in melanoma, the response rate in PD-1 only treatment is about 40%. So this is much higher here in Merkel cell carcinoma. And also interesting, the virus status. So if the patient, if the tumors were Merkel cell polyomavirus positive or negative, this did not play any role. So this was not a predictor of treatment response. So subsequently, there were other trials. The first was with pembrolizumab. Then we had nivolumab, which was in first and second line. And then we had a second line trial for avelumab, which then led to the approval of this drug for Merkel cell carcinoma. So we had high response rates with all these agents, PD-1 or PD-L1 blockers, in first line 50 to 70%, in second line still 30 to 50%, and we had high numbers of durable responses, which is quite nice. Here's a case from our clinic here in Essen, a patient with organ metastasis and also cutaneous and subcutaneous metastasis of Merkel cell carcinoma. And as you can see, after treatment with avelumab, here at 6 weeks of treatment and here at 12 weeks of treatment, you see a nice tumor shrinkage. And this was also the case in organ metastasis. This is the same patient. He had a very large abdominal metastasis, which was much, much smaller after 3 months of avelumab. So very nice responses, so that we can say there can be a treatment recommendation for PD-1 and PD-L1 inhibitors for Merkel cell carcinoma. And this is important to know. In first-line treatment, the response rates are much higher, 50 to 70%. In second line, after chemotherapy, response rates are lower, which led to the recommendation, at least in the German guidelines of the ADO, that immune checkpoint inhibitors should be used in first line. And chemotherapy should be postponed to second line therapies of checkpoint inhibitor refractory patients. What about predictive biomarkers? So how can we know if a patient responds, will respond or not respond to an ICI, to a checkpoint inhibition? Interestingly, we do not have very nice predictive biomarkers yet. I already told you the polyomavirus status is not a predictor, and this was a little bit stunning. PD-L1 expression is also not predictive. So this is different from melanoma. Here we have a very nice correlation. PD-L1 positive tumors show better responses this is not the case in Merkel cell carcinoma. We do not yet know why this is the case. So there is a strong need for predictive biomarkers here. Then another problem that we have is acquired resistance. Of course, we have primary resistance, so patients who do not respond to PD-1, PD-L1 blockers, this is clear, but then we have also acquired resistance, early and late. And this acquired resistance is common and is more often seen than, for example, in melanoma. Here's a patient, again here from our clinic in Essen. Here you can see some cutaneous metastasis from Merkel cell carcinoma. The patient also had lymph node metastasis, but you can see here with pembrolizumab treatment, these metastases were very nicely responding. He had more or less a complete response, and this was a partial response because of his lymph node metastases. But here you can see at 12 months, so 6 months later from this point here, you can see that these metastases are still in remission, but here are new lesions rapidly growing, and this patient is 6 months later, he died from Merkel cell carcinoma. So the question is, what do we have as rescue treatments for these patients? And at the moment, we do not have a lot in our pocket, I have to say. One is, of course, chemotherapy. And then we have clinical trials actually ongoing. One is the so-called Merkel 2 trial. This is again with domatinostat, which was already shown to us by Christian Blank. Here the patients receive avelumab plus domatinostat with the goal to rise the immunogenicity of these tumors again. Another trial is here with an MDM2 inhibitor. This is also meant as a rescue treatment for patients after progression upon PD-1, PD-L1 inhibition. So again, to come back to the clinical predictors, we did some workup in a first study we published in 2020 on about 40 MCC patients. Here we tried to find clinical predictors, so characteristics that we can measure at treatment baseline and then which could be associated with immunotherapy response. But we found that there are only very low numbers of clinical predictors. One is immunosuppression. So patients with an immunosuppressive state, like for example with hematologic malignancies or with long-term corticosteroid use, these patients do show a much poorer response to PD-1 and PD-L1 blockers, but this is more or less something we would anticipate. And then patients with a poor overall performance status. But not predictive were sex, age, primary site, which we before anticipated to find here something about the primary site, like extremities versus trunk, then disease stage, pre-treatment stage. Here in our analysis, pre-treatment with chemotherapy was not predictive, and also not serum LDH or CRP. Then we did some molecular analysis on pre-treatment tissue of these patients, and we again confirmed that PD-L1 expression was not predictive for treatment response to PD-1 blockers. But interestingly, we found that tumor-infiltrating lymphocytes, which were predominated by central memory T cells, these tumors had a very high probability to respond to PD-1 blockers. Then just very recently, some weeks ago, we published another larger study, this time in more than 100 patients in a multi-center setting to detect these biomarkers again. Here we found a treatment efficacy of 65%, disease control rate in this real-world patient population. And here we could find some more predictive biomarkers. We used another approach, a so-called Bayesian model. And here you can see the red characteristics here. These were the strong predictors of a good response. This was again, no immunosuppression and a limited number of involved organs. So if only one organ is involved, this is much better than 2 organs or more. Then in orange, moderate predictive biomarkers. This is an unimpaired overall performance status. High age, interestingly. High age is better than younger age for response to PD-1 blockers. Normal ADH in serum and normal CRP in serum. Again, PD-L1 expression and polyoma virus expression was not predicted. And this is the kind of predictive model we then suggest to use in clinics. If you would, it would try to predict if a patient will respond to PD-1 blockage, yes or no. Favoring disease control is no immunosuppression, high age, ECOG of 0, and in the tumor, only 1 organ involved, and a strong infiltrate of effector or memory T cells, normal ADH, and normal CRP. And this is just a little outlook. It's my last slide. In a current project, we try to analyze with single cell sequencing if tumor infiltrating macrophages play a role for the response of Merkel cell carcinoma to PD-1 blockade, because we have some preliminary data suggesting that this could be the case. So maybe this can be one of the next stories. Thank you for your attention.
Thank you very much, Selma. I think Merkel cell carcinoma is really a paradigm for immunotherapy. And I see Matthias is back. So I think Merkel cell carcinoma is one of the tumors where radiotherapy is very important. I think there are no randomized clinical trials, but from retrospective trials, radiotherapy is really seems to be beneficial. Do you have any ideas why this is the case? And are there differences from Merkel cell virus positive versus negative outcomes if we use irradiation therapy?
No, we do not yet have any markers or predictors if a patient will be one of the relapsers or not, but I have the feeling that Merkel cell carcinoma is much quicker in changing, like epitopes, immunogenicity. It's not like melanoma, where once you have a strong immune response, this is persisting for months and years. So here we have many patients with Merkel cell carcinoma who are first responding, stop to respond within the first year of treatment. Mm-hmm. So this is quite early. Mm-hmm. And yeah, it's interesting to see, and I think we have to respond to this in the clinical management. I can see that here is a question in the chat about this. Mm-hmm. So it's written, how does late acquired resistance change treatment duration and management? And this is exactly the case. So we, for melanoma, for example, if a patient achieves a very stable partial response or even complete response, then we often treat for 6 additional months and then stop treatment. And this we do not in Merkel cell carcinoma, because here we have the experience that patients are so often relapsing that we recommend to go on with treatment. And if the patients are kind of tired of treatment, especially with avelumab, which has to be given every 2 weeks, then we just enlarge the intervals. Like, for example, give avelumab every 3 weeks and then every 4 weeks, but hold the patient on treatment.
Okay. Any additional questions? I thought you showed us that MDM2 inhibitors are considered to be used. Is there in vitro or model systems that show that these drugs are especially important or beneficial in Merkel cell?
Yeah, not really. These are not very convincing data, I have to admit. I just wanted to show it because it's currently in Germany accruing clinical trial. We are also participating here in Essen, but it's not very convincing. I don't think that this is a future strategy. But the other one with domartinostat, of course, is interesting.
Okay, some more questions. So Matthias, do you have any explanation why Merkel cell carcinoma seems so sensitive to irradiation treatment?
I mean, the issue is not that Merkel cell carcinoma is sensitive to radiation. I mean, it's used in the localized setting as an adjuvant, and as you mentioned, as a palliative treatment. If there's disease sites where you need some kind of palliation and local control. The issue is that at least our current understanding, radiation does not contribute in the metastatic setting to evoke this, call it abscopal or systemic immune effect. That is something which could be investigated or kind of addressed, but at least I don't know convincing data for Merkel cell carcinoma. Are there specific data?
Yeah, actually, no, there are no specific data, but we have the clinical experience that it's very nicely fitting together with immunotherapy. So much better than in melanoma. We have patients with immunotherapy plus irradiation who have such a strong and long-term complete response, so that I'm not convinced that this would be as good without irradiation, so with immunotherapy only. But we don't have clinical trials proving that. This would be a very nice trial, actually.
And that was in the palliative setting, what you described, or
in the palliative setting. Yeah. Like, for example, in patients who have multiple cutaneous, subcutaneous lesions on extremities or on the trunk, which are shrinking and disappearing within weeks in patients treated with immunotherapy plus irradiation. Mm-hmm. So I think this is a very nice concept in this tumor.
And just the last question, so if we have the virus, does immunotherapy cause a induction of specific clones against viral antigens during the treatment of checkpoint inhibitors? Is this investigated?
I must say, I don't know. I'm afraid not. I think it's not that important that that the immunotherapy triggers the antiviral clones, yes or no, but it's about the anti-tumor clones. I think the virus on the Merkel cell carcinoma cell, so on the it's not that good detected there.
Okay, it's not a good tumor antigen.
I think exactly. I think Jürgen has had some data on that, and then it was not so convincing as you would anticipate, actually.
Okay. So thank you so much. I think we had 3 excellent presentations, very stimulating for the field of immunotherapy in all cancer types. Now we have half an hour break and we will meet again in 5:05 at 5:05. See you later.
Yeah, please join us in half an hour. Have a good break. Ja, also ich denke, wir warten jetzt einfach eine halbe Stunde oder können einen Kaffee trinken.
Genau, können wir einen Kaffee trinken. Leider nicht zusammen.
Ja, das
Leider
fehlt
nicht
jetzt.
zusammen. Also ich danke euch ganz herzlich für die hervorragenden Vorträge. Es hat echt Spaß gemacht, aber es wäre natürlich noch schöner, wenn wir jetzt dann zusammen irgendwo in der Zürcher Zunfthaus gehen könnten, gell? Matthias, mit unseren Gästen.
Das
wäre
vermissen wir, genau.
Ja.
Ja, schade. Ich hatte mich
Vielleicht
schon
laden wir euch
wieder.
dann trotzdem einfach für was anderes mal ein.
Reinhard, nur um das dir nochmal zu sagen, ich konnte das nicht so gut erklären, ehrlich gesagt, weil das auch nicht so, das ist ja mehr so Jürgens Ding, aber es ist ja tatsächlich so, dass das ist ja nicht so wie ein Virus, das jetzt akut da ist, sondern dieser Virus-Hit bei Merkel-Zellkarzinom, das liegt ja Jahre zurück. Man findet da zwar noch die DNA drin sozusagen, aber es ist nicht so wie ein akut infiziertes Ding und deswegen präsentieren die das nicht so. Und das ist nicht kein aktiver immunogener Trigger, wenn man sich das so vorstellt.
Also es sind keine virusspezifischen Peptide auf der Oberfläche, die dann über Klasse 1 und Klasse 2 präsentiert werden.
Genau. Ich sehe hier gerade, alle Teilnehmer können noch zuhören. Schreibt hier gerade jemand, okay. Macht ja nichts, dann hat man das vielleicht noch mal so verstanden.
Okay, dann haben wir das nochmal angeschaut. Ja gut, dann.
Aber das macht jetzt auch nichts. Also das sind jetzt keine geheimen Gespräche gewesen.
So ist
Genau.
es.
Die geheimen Themen kommen jetzt, können wir jetzt erstmal noch separat dann besprechen. Ja gut, okay. Also,
okay, also dann bis in einer halben Stunde.
Bis in einer halben Stunde. Bis dann.
Danke.
Tschüss.
Vielleicht ganz kurz, Herr Heikenwälder. Sie habe ich schon kurz aufblitzen sehen.
Ja, ich bin da und ich höre. Ich bin da und ich höre im Hintergrund. Ich bin da, ja, ja.
Hallo.
Super, weil da können wir vielleicht ganz kurz einen Techniktest machen in der Pause und können dann nachher um 5:05 Uhr direkt loslegen. Vielen Dank erstmal fürs Zusagen, fürs Dazukommen.
Ja, ich freue mich sehr, war auch sehr spannend. Und mein Talk wird ja auch über Immunotherapie laufen. So gesehen, glaube ich, ist es ganz spannend, da anzuschließen.
Und wieder mal gut zurück in Zürich zu sein, wenn es auch leider nur virtuell ist.
Ja, das ist korrekt. Ich hätte mich wirklich gefreut, auch nach Zürich wieder zu kommen und viele Leute halt kennen oder zu treffen wieder, die ich kenne. Das beginnt bei Achim Weber und hört auf bei Adriano Aguzzi, aber so ist es halt. Diese Zeiten sind halt doch ein bisschen schwieriger.
Genau.
Gut, dann gehe ich das mal durch, aber es wird keine Probleme geben. Da bin ich mir hundertprozentig sicher.
Genau. Also Sie teilen den Bildschirm selber, oder?
Ich teile den Bildschirm jetzt gerade in der Sekunde.
Super.
Und man sollte den jetzt schon sehen. Dann
Sieht
mache ich
perfekt aus.
auf Präsentationsmodus. Präsentationsmodus ist auch schon drauf. Und dann werde ich jetzt noch kurz meinen Laserpointer anschalten. Dann ist der Laserpointer auch da. Ich hoffe, den sieht man.
Ja.
Hervorragend.
Und dann geht schon los mit der Präsentation.
Klasse.
Ich glaube, das sollte alles gut gehen. Oder Sie sehen jetzt gerade die Overall Survival Kaplan-Meier-Curves. Okay.
Wir sehen das perfekt. Bild und Ton ist einwandfrei.
Super, dann freue ich mich und bis gleich. Ich werde 5 Minuten davor schon da sein. Ja, damit
dann gerne noch mal kurz raus aus der Präsentation. Sonst.
Ja, sehr gerne.
Ja, danke schön.
Bin aus der Präsentation raus und würde mich dann einfach um 16:55 dazuschalten.
Ja.
Ist das gut? 16:45?
Ja, 16 Uhr reicht auch noch, ja.
Gut, also 17 Uhr wird auch noch reichen. Okay, dann bin ich um 17 Uhr drin.
Ja.
Gut, alles Gute, bis später, danke.
Tschüss.
So, wir sollten jetzt alle in der richtigen Stimmung sein nach der Musik.
Ja.
Das war irgendwie fast so ein bisschen Bacardi-Feeling.
Beim nächsten Mal suche ich was Ruhigeres raus.
Für Züricher Verhältnisse auf jeden Fall.
Was sind denn die Heidelberger Verhältnisse?
Oh, die Heidelberger Verhältnisse sind natürlich 4 Grad wärmer, Palmen und die famose grüne Wiese, die Neckarwiese vor dem Neckar, in dem man nicht reinspringen soll, weil er ja nicht ganz so sauber ist. So gesehen. Nee, so gesehen ist es natürlich in Zürich viel schöner, das weiß ich aus eigener Erfahrung. Aber die Musik würde auf jeden Fall auch in Heidelberg gut ankommen.
Aber wir sind alle pünktlich zurück, das ist super. Hallo Reinhard.
Ja.
Hallo, hallo. Freue mich auf den zweiten Teil.
Genau. Wir hoffen, dass viele auch noch dabei geblieben sind über die Pause.
Ja, bei mir steht da 93 Teilnehmer noch, das sieht gut aus.
Das sieht gut aus, genau. Und wir haben sogar noch ein paar Minuten Zeit.
Ja.
Super. Ja, also Zürich war bei mir eine sehr schöne Zeit. Ich kann mich da noch sehr gut dran erinnern und das war wirklich fantastisch. Und ich komme gerne, wir haben noch viele Kollaborationen.
Gewesen? Sie waren im Laboratory am USZ oder waren
Ich war am USZ in Adriano Aguzis Labor
Genau.
und war dann auch in seiner Gruppe Gruppenleiter und das wäre jetzt heutzutage, würde man das Assistenzprofessor nennen, das Max-Klötter-Professor war ich da für einige Jahre und bin ja dann nach München gegangen, direkt von Zürich, genau. Und jetzt seit 7 Jahren in Heidelberg, genau.
Da hätten wir eigentlich speziell Adriano noch mal einladen müssen, Reinhard, das haben wir verpasst.
Eben, ja, genau.
Ich denke, Adriano, sind wir eigentlich jetzt intern oder sind wir Common Shared?
Wir sind common, wir sind offen, wir sind voll auf dem öffentlichen Kanal.
Super.
Wir funken sozusagen in die weite Welt.
Sehr gut. Wäre natürlich schön gewesen. Ich habe ihn jetzt schon länger nicht mehr gesehen, aber werde ihn sicher mal wieder sprechen.
Man trifft ihn auf Twitter.
Genau.
Er twittert regelmäßig, genau.
Ich glaube jetzt nicht, jetzt gar nicht. Jetzt trifft man ihn gar nicht mehr auf Twitter.
Ehrlich?
Ich glaube, er ist nicht mehr auf Twitter jetzt seit, ich weiß es nicht. Ich verfolge das nicht so ganz genau.
Hi Fernanda, good to have you back.
Oh, hello.
We're still missing one. Ein Speaker fehlt noch, Silke. Ping Shi Ho.
Ja, aus Lausanne.
Hat aber bestätigt und mir auch die Präsentation geschickt.
Okay, aber hat er auch noch ein bisschen Zeit, ist eine halbe
Stunde. Ich schaue.
Ein bisschen zuversichtlich.
Nein, ist ja toll, gerade Richtung Immunotherapie und Liver Cancer haben wir auch die eine und andere Kollaboration mit Zürich, USZ gehabt. Also das sind sehr viele Verbindungen noch da, auch immer noch. Von Achim Weber in der Pathologie angefangen bis das Clavien-Labor, da haben wir auch sehr viel gemacht, Pankreatitis, aber auch Hepatitis. Also das wird immer sehr intensiv bleiben, denke ich.
Ja, das ist ja das Schöne, wenn man ein paar Stationen hat, dass dann doch immer irgendwo Beziehungen hängen bleiben und ein Netzwerk dann doch, sagen wir mal, stabiler wächst als nur auf Kongressen.
Genau, wobei die letzten 2 Jahre ist das ja gar nicht möglich. Ich war vor kurzem in Amerika auf einem so Keystone-ähnlichen Meeting, das heißt NASH-Tag, das ist so eine Konferenz für NASH und klinische Anwendungen. Und da frühstückt man in der Früh und allein da die Gespräche, die man in der Früh gehabt hat, das kann man in einer Breakout-Session gar nicht durchführen. Das ist, weil man von irgendwann zu irgendeinem Zeitpunkt im Gespräch auf eine tolle Idee kommt, die jetzt absolut aus dem Kontext gerissen ist, aber kontextdependent, wo man gerade ist, das hat man in einer Breakout-Session nicht. Also das ist wirklich etwas, was einem abgeht bei Meetings. In der Tat.
Ab März, was ist die Wette? März, April?
Da ich wette gar nichts mehr in der Beziehung. Ich enthalte mich der Stimme.
Ja, das ist, glaube ich, richtig. Bisher waren wir alle falsch gelegen, glaube ich.
Ich hoffe, es wird besser werden. Das ist das Wichtigste, ehrlich gesagt. Aber wenn man sich das ansieht, weil wenn man sich ansieht, was so auch in Deutschland und Österreich gerade passiert, trotz der klinischen Studien und der Daten, die darauf hinweisen, was ICUs betrifft und so weiter. Und dann wird trotzdem alles gesperrt und geschlossen. Dann, ja, dann gibt es da vielleicht eine andere politische Agenda.
Also bei uns sind jetzt, glaube ich, habe es gar nicht gelesen, dass du es gelesen, Reinhard. Viele Maßnahmen sind eigentlich wieder aufgehoben worden vom Bund. Ich glaube, Maskenpflicht bleibt noch im Wesentlichen erhalten.
Ja, bleibt noch.
Pflicht ist, glaube ich, aufgehoben.
Ja.
Okay, I would say it's 5 minutes past 5, so let's get started. Thanks everyone for coming back to our symposium. We had some kind of fancy music in between, so I hope you're in a good mood, in particular being active. So you have been dancing in between and now can kind of contribute actively to our symposium and the discussion. It's a pleasure to announce the next speaker, who's Matthias Heikenwälder. He has studied in Vienna in microbiology, in microbiology medicine, then spent some time in Berlin, and then spent quite a large number of years here in Zurich in the Institute of Neuropathology of Adriano Aguzzi, where he also finished his habilitation, then moved on to Munich and now is for almost 7 years in Heidelberg, where he is leading a research focus on chronic inflammation and cancer, which is also why we invited him. The topic of his talk is going to be the immunological and metabolic landscape in primary metastatic liver cancer. Matthias, many thanks for joining. We're looking forward to your talk and hoping for an active and lively discussion afterwards. Matthias, the floor is yours.
Matthias, thank you so much for the kind introduction, and also thanks for the invitation to the whole committee and consortium of the CCCZ in Zurich. And I'm going to share my screen right now. I hope you're going to see the screen in a second. And we'll go on presentation mode, turn on my laser pointer, and then we can go into this race. So laser pointer is on. I hope you're gonna see the laser pointer now as well. Do you see the screen in presentation mode?
All perfect.
Hello? Yes?
All perfect.
Perfect. Do you see the screen in presentation mode?
Okay, perfect.
So then I get started. Thank you so much. So the topic of my talk will also actually touch immunotherapy of liver cancer, specifically in the context of fatty liver disease, which is one of the really emerging, exploding liver diseases in Europe and the United States. So when you think about the etiologies that drive liver cancer, which still is the fourth most common cause for cancer-related death in humans, it's very clear that there are several etiologies. Number one, of course, still is, in a global scale, HPV and HCV infection, which causes chronic hepatitis, liver damage, regeneration, and liver cancer. But more and more, actually, other etiologies come to fore, which is on one hand, non-alcoholic steatohepatitis or NASH, or alcoholic steatohepatitis ASH. As you know, combination thereof is very frequent. It's called BASH, or also MAFLD for metabolism associated fatty liver disease. And we now know that alcohol intake in the context of unhealthy lifestyle with hypercaloric, high-fat diets is really amplifying massively, like tenfold the risk of liver cancer. What's happening in the liver? Well, you have a chronic state of regeneration, of ROS, of ER stress, which on the whole will shape the liver microenvironment in combination with regenerative processes to cancer. And we now know that these primary cancers, hepatocellular carcinoma or cholangiocarcinoma, HCC being the most important, 80% of all primary cancers are HCC. They have actually different types of histological patterns. I just show 4, but there are ample more. And they also have a completely different type of tumor microenvironment, metabolism, as well as molecular biology. So it's an extremely heterogeneous disease. And that is why this disease is also so difficult to treat. As a take-home message, however, is that all these diseases underlie chronic necroinflammation. So chronic necroinflammation and hepatitis is really the driver of those diseases. Now, in the past 2 years, there was a paradigm shift in treating late-stage HCC. So this is the classic, a patient comes to the clinic, he does not know that he has liver cancer, obviously, but there are some clinical parameters that indicate that something's wrong with the liver. And then in the hospital, it's diagnosed that this patient has liver cancer, for example, HCC. And then before 2 years ago, systemic therapy, including pan-tyrosine kinase inhibitors, such as sorafenib or regorafenib, was used. Now, however, in the context of immunotherapy, there was a shift in the treatment. And as of today, as you see here in blue, the combination of an anti-VEGF inhibitor and an immunotherapy treatment, atezolizumab and bevacizumab, became much more efficient when it comes to the overall survival. So this was published 2 years ago. Just last year, the outcome of this study, of the IMBRAVE study, was published completely. And you see, yes, indeed, there is a better survival and also, most importantly, a better quality in life. We've heard about this by a previous speaker, that this is important. Sorafenib, regorafenib, they also can cause potential bleedings. And for example, you cannot take a liver needle biopsy from those patients if they are on pan-tyrosine kinase inhibitors. However, I should tell you, and that's really the problem that you see actually here, at the end, the overall survival after 5 years doesn't really massively change and drastically change. We still have this classical 20-25% survival after 5 years. And I think we all agree that in the year 2022, this is not enough what we would like to provide to our patients. And moreover, I should say, it was not clear at that time point which are the patients that respond and which are the patients, the 20% of patients that really respond well. And that is why I would like to convince you today that we can stratify patients that are responders and non-responders, and we can work on overcoming resistance, but we can also work on making the responders even respond better. So what is NASH actually? Just to give you an overview. So NASH is a disease, it's called non-alcoholic steatohepatitis, which is actually based on pathological criteria, and it stems from a disease which we can call fatty liver disease or steatosis. Every third European suffers from this disease at the moment, and it is not quite well understood what's actually the driver of the transition from this steatosis, which is not really pathologic, apart from the fact that the liver doesn't metabolize well, to NASH, which is this pathological state, which I'm going to introduce in a second. It is, however, known that in this transition from NAFL to borderline NASH to NASH, we have patients that can develop liver cancer in the absence of fibrosis and cirrhosis. And we have patients that can develop liver cancer in a stepwise process through fibrosis and cirrhosis, either leading to liver dysfunction and liver failure, which needs to be transplanted. And NASH is one of the most important reasons for transplantation already today, or then directly from fibrosis cirrhosis develop in the context of NASH towards HCC. What are the modifiers? Sedentary lifestyle, metabolic syndrome, high caloric intake, obesity as such is very clear, insulin resistance, type 2 diabetes. There are some genetic modifiers like a locus called PNPLA3, but in terms of numbers, not very important, but it could be a driver, and age. The older you get, the higher the risk to have a fatty liver disease. So how do you model this in a mouse model setting or in a rat? You can even do it in a pig. We have decided to do long-term diets, either classical Western diets with high fructose, cholesterol, and high-fat diet, or choline-deficient high-fat diets, because it has been shown that choline deficiency is one of the drivers in the transition from steatosis to NASH. And what we have seen is that, in contrast to many other diets, our mice really over a year gain massive amount of weight, and on top, in serology, but also in non-invasive imaging, display actually real deposition of fat in the liver, as indicated here as a dark image, or as indicated here in the subcutaneous and abdominal fat as a white image. Moreover, we could show that our mouse models, after 1 year or longer, develop a histopathological feature of Mallory-Denk body, steatosis, ballooning, satellitosis, exactly what you see in the human liver. So this is here a human NASH compared to our murine NASH. And concomitant with this, we have ROS, we have development of fibrosis, different degrees depending on the diet. There is not one NASH, obviously, there are different diets like in the human situation, and inflammation. And the chronic inflammation is very peculiar because, in contrast to hepatitis induced by viruses, it's a very dispersed inflammatory disorder. And by doing actually histology, single cell RNA-seq analysis of mouse models and humans, we can really show that, at least as far as CD8 T cells concerns, our model recapitulates the human situation. So what happens in these mice? These mice develop hepatocellular carcinoma after 12 months, 25% to 30% incidence, depending on the mouse colony and the housing of the mice. And over time, this after 18 months can develop towards an incidence of 50%. You also see that overall, in a nutshell, the genetic aberrations, so chromosomal deletions or amplifications, in a nutshell, recapitulate what you would see in the human situation. Obvious, as I told you before, it's extremely heterogeneous, but when you put everything together, the hotspots of mutations we also see in our mouse model. So by doing these experiments, we have actually found unexpectedly that adaptive immune cells, such as CD8 T cells and NKT cells, crosstalk with hepatocytes, metabolically reprogram hepatocytes, and induce the transition from the non-pathogenic steatosis to NASH, which is the precondition to develop liver cancer. And it was very, very striking for us to see that we could identify similar inflammatory, metabolic, as well as liver cancer signatures in human patients with NASH. Now, what is this interaction that these immune cells do with hepatocytes? And it was very striking to see in our mouse, but in human NASH, that something very peculiar and funny happens. You would expect if a liver is tortured and stressed with high caloric lipids and with sugars and different pathways, that actually the whole machinery should be induced to help the hepatocyte to metabolize the incoming metabolites per se. But that is actually not taking place in NASH livers, meaning livers that have the pathology and inflammation. All these pathways, may they be important for fatty acid oxidation, lipolysis, or cholesterol metabolism, are downregulated. So the liver has two problems. Number one, incoming metabolites and lipids. Number two, a reduced metabolic machinery. And that is actually the reason why these hepatocytes accumulate lipids in their cytoplasm, and also why there are extracellular lipids, because simply metabolism doesn't work. And for us, the first experiment a couple of years ago, by the way, actually already done in Zurich, indicated that when you genetically take away B and T cells and these mice develop obesitas, metabolic syndrome as a wild-type mouse, the livers, however, didn't show steatosis at all. And one of the reasons, or at least correlations that we could find, is that many genes that are massively downregulated were prevented in the downregulation when you do not have adaptive immune cells in the liver. So to speak to summarize this first part, this crosstalk of adaptive immune cells with hepatocytes in cell-cell contact or by secreted factors reprograms the metabolism of hepatocytes and thereby co-drives actually NASH. And secondly, as I will show you today, these activated CD8 T cells, which you might believe are anti-tumorigenic and so on, are actually drivers of liver damage per se in an autoaggressive fashion, and they drive liver cancer. So to really investigate this interaction between immune cells and hepatocytes, we recently have generated a novel technology that enables us to do in situ single cell metabolism of hepatocytes. Why hepatocytes? Because hepatocytes are huge, and then you can do a multi-TOF analysis. You can do, so to speak, a shooting with the laser in a random fashion in vitro, but also in your slice. And you can analyze the metabolism of hepatocytes, for example, being surrounded by immune cells and performing a multicolor immune fluorescence analysis. And that enables us for the first time in this setup that we, together with Theodore Alexandro from Embryl, established and we called Space M, to really perform a quantitative and a qualitative analysis of approximately 300 metabolites and 300 lipids. You might say, well, that's not so much, but actually it's a lot to analyze hepatocytes in their structure and in their phenotype. And you can go from morphological features to spatial features. You can combine them with stainings, and you can look at different types of metabolites in a qualitative and quantitative measure. Now, what does this mean, and why have we been doing this? Well, number one, to do co-culture experiments with hepatocytes and immune cells. I'll not bore you with that, but it's very clear when you co-cultivate hepatocytes with a lot of activated T cells that we can prime beforehand with lipids and metabolically activate them, then it's exactly happening what we have shown in vivo. But moreover, what you can do is, and that's the more thrilling thing for us at the moment, that you can actually trigger inflammation in these for example, cell cultures that where we use here in this particular case, differentiated human helper T cells. But what it shows you is, and this is the whole panel of metabolic states that hepatocytes can have. Here are the controls, and here these are the different treatments where we combine cytokines only or different cytokines or agonists with fatty acids. And what really is striking is that you see that there are different flavors of NASH, because this is like a principal component analysis summarizing all these 300 metabolites and lipids put together and centered on one single dot represented by one cell. And you can see if you combine all cytokines and fatty acids, they really shift towards a NASH state. And here TNF is really one of the important triggers. But you also see that depending on which receptors you agonize, you get different states of metabolism. And that's super interesting because this is very important when it comes to the metabolic environment in the liver and the correlated inflammatory state. And by doing this and by identifying these different states and signalings, we can now for the first time actually understand better the spatial regional distribution of metabolic capacity and why, for example, particular immune cells in particular zones of the liver have a particular function. To size this technology and to investigate this immune cell hepatocyte crosstalk, we could really show that the intimate vicinity of immune cells to hepatocytes is indeed needed, and it can be secreted by factors. It can also sufficient to have cell-cell contact to actually induce this metabolic reprogramming, which is really at the basis of the pathology. Now, with this data that this crosstalk between adaptive immune cells and hepatocytes is important, we further screened, we wanted to understand why do actually metabolically activated CD8 T cells go into the liver for the first place. And strikingly, what we found, there is an innate immune cell type, it's platelets, which actually get activated and get adhered to the liver in the context of metabolic stress by binding with their CD44 receptor, particular danger molecules that give rise to accumulation and aggregation of platelets in the liver, in the parenchyma, where actually the stress and the metabolic damage happens. And that actually induces activation of platelets to secrete exosomes that are filled with cytokines, and that is really important for the attraction of CD8 T cells and NKT cells, which is then the starting point for the pathology. Now you could say, well, mouse model system, what does this mean? Well, first of all, we were able to use a classical antiplatelet therapy using aspirin clopidogrel in the context of NASH or NASH to HCC transition to prevent NASH, or also to reduce NASH incidence if you do it in a therapeutic fashion. But moreover, we performed a small clinical trial with patients that had developed fatty liver disease and were treated for half a year with aspirin only or aspirin clopidogrel, and we could revert actually NASH in this half a year and could also reduce liver volume up to half a liter in some of the patients. Now, of course, you would never ever want to use aspirin clopidogrel in the context of NASH by elderly patients, for example. So that is why we have found out the molecular mechanism. There is a receptor on platelets that is important for inducing this inflammatory response. It's called GP1B alpha. And we have now generated anti-GP1B alpha antibodies with which we can play the same trick with aspirin clopidogrel, and this is now going into GMP production and toxicology on the way to hopefully perform soon, maybe soon meaning 2 years from now, maybe first phase 1 clinical trial. What we also have found that in the context of this inflammatory attraction of adaptive immune cells, there is also an immune activation needed, and there are particular dendritic cells that appear to be very important. These are conventional dendritic cells, type 1 conventional dendritic cells, and we believe actually, we don't know how that works really, but in a classical antigen-independent manner, activate these CD8 T cells and NKT cells to drive disease. And that, of course, was very interesting for us to see this interplay of innate immune cells that then further drive activation of T cells. Now, in the context of this whole scenario, what we have seen is that over time with pathology, in the human situation, but also in the mouse, there was this very interesting induction of CD8 PD1 T cells. So we can use different types of diet. I introduced them to you. And over time, these mice actually increase their body weight. They over time increase to a particular plateau liver damage. You can score this with the so-called NFLD, so fatty liver activity score, pathologically, and this was going up. And concomitantly with this rise in pathology, we actually have seen this rise in CD8 PD-1 positive T cells, done double stainings and multicolor fluorescence analysis. So this is this red population. And obviously there are many other populations that are also changed to some degree or reduced or increased, but that was the most apparent for us. And it was also most apparent, of course, in the context of possible immunotherapy, because if you have these exhausted T cells in NASH, then it's obvious that maybe immunotherapy would be very important, and it would maybe give us an idea which patients would respond to immunotherapy or not. But by analyzing then on single cell level in the human situation and in mice, in NASH patients and NASH mice, we have seen something very weird. And the weird thing was that the CD8 PD-1 T cells, which you see here to be increased, number one, are always the aim of destiny when it comes to non-spliced mRNA transcripts, and you do velocity plot analysis. So you look into the future of single cell RNA-seq cells, you see that they all go towards the direction of PD-1 CD8. So apparently all the cells want to go in this PD-1 CD8 activated state. Secondly, what turned out is very interesting, that these exhausted T cells at the same time looked unconventionally activated. So they had high levels of granzyme B, high levels of granzyme K. So I refer here to the lowest row of CD8 T cells, indicative of the fact that we have both at the same time. We have exhausted T cells that appear to be very hyperactivated, expressing the classical markers of exhaustion like TOX, like 3 TIGIT, but also having a lot of cytokines being expressed at high level. And to cut the long story short, what we could show also together with Percy Knolle is that these CD8 PD-1 T cells, they are actually resident T cells. They express a marker called CXCR6 or CD103, and they are somehow hyperactivated by the dyslipidic environment in the liver and get furthermore activated by acetate and ATP produced by the stressed hepatocytes. So autoaggressive T cells, and we could show that these autoaggressive T cells, they kill everything independent of an MHC class or antigen-dependent mechanism. And that is maybe the reason why these cells most likely contribute to the damage that we see in NASH. Now, is this really something that happens in humans? Yes, this is the case. So when doing different types of cohorts, we studied altogether 5 different cohorts. We could show even that there is this gradual increase from steatosis, borderline NASH to NASH, and we could even identify pathways to be very strong, one of which being antigen presentation, focal adhesion, also T cell receptor signaling. So TCR is activated, but it's activated in an antigen-dependent, independent manner, and it's actually downstream of the TCR where we see this, let's say, autoaggressive chronic signaling. We could show that this accumulation of T cells, like in our mouse model, goes together with the progression of the disease, in this particular case with the progression of fibrosis. So the higher the stage of fibrosis goes, the more cells we could see. And that indicated, okay, now let's do an experiment. Let's take mice that have NASH-induced HCC and treat them with immunotherapy, like in the human situation. And we did this. And so we selected 2 treatment arms, one of which were treated with immunoglobulins and the others with less. And to cut a long story short, unexpectedly, where we thought maybe, this is, beneficial to the mice, it turned out that these mice do get more tumors. Now you could say, well, maybe they get more tumors and, they get more damage because, maybe the T cells don't even get into the liver or something like this. But turned out that actually within the tumors, we've seen a lot of T cells, and we've seen a lot of T cells that really were activated. So maybe autoaggressive. So, well, it could be that mice in general don't respond in liver cancer to immunotherapy, but that's not the case. By looking at different tumor mouse models with liver cancer, we could show that in the absence of NASH, they are very receptive to immunotherapy. Now, then we said, okay, this is the therapy. Let's go to the chemopreventive or to the preventive setting and do the immunotherapy treatment or the T cell depletion treatment in the time at which tumor is just developing. So in the phase from NASH to HCC. And to cut a long story short, when you deplete CD8 T cells, you could actually block beautifully the development of liver cancer. So as if the CD8 T cells potentially might be the driver of the disease. Vice versa, when doing the immunotherapy treatment, similar to what I've shown you before in the therapeutic setting, we do see actually that there is an increase, even slight, in damage. We do see that there is an increase, slight, in pathology. And we also have seen an increase, obviously, in these inflammatory cells. So what happens with cancer? Well, cancer is massively increased. Incidence 80%. So as if, at least in the mouse setting, it looks like that immunotherapy is actually driver of disease in the context of NASH activating CD8 T cells. So last couple of slides, what happens to the CD8 T cells? Are they now different, or what does immunotherapy do to these CD8 PD-1 T cells? Again, to cut a long story short, it doesn't do anything. So the non-treated CD8 PD-1 T cell that you see in NASH or NASH HCC compared to the immunotherapy treated looks identical, almost identical. It looks very similar on protein level. It looks almost identical on transcriptional level. So the targets we see under anti-PD-1 treatment are the same targets we see without. So it is not that there is a change of these cells, but there is a change in number. So the number of the CD8 PD-1 T cells and the stabilization of their proto-oncogenic signaling is increased. And as a consequence of this, what we see is indeed that immunotherapy in the context of NASH induces an oncogenic signaling, and it induces an inflammatory signature, which we call ICF signature here in red, which is massively correlated with liver cancer development. For example, in the depletion of CD8 T cells, this is completely abrogated, although these livers still have NASH. We have, or NASH pathology. We see an increase in oncogenic signaling, one of which is P62, but there are other signalings like KRAS. And most importantly, we see this increase in damage per se. So the immunotherapy in context with CD8 T cells that are PD-1 positive and have this residential character, once treated with PD-1, they are even more stabilized and they contribute to local damage nearby where the T cells sit in green and the apoptotic cells, hepatocytes, for example, sample in red. Now, is this of any relevance to the human situation? So we went back to approximately 4 cohorts, including more than 2,000 patients, immunotherapy cohorts, and one of which is the IMBRAVE study, which I alluded to at the very beginning, combination of anti-VEGF with anti-PD-1, anti-PD-L1 therapy. And what we could show is, again, also in those patients that are non-viral, presumably NASH, non-alcoholic steatohepatitis, or alcoholic steatohepatitis, respond less efficient and sometimes even favoring control when compared to the viral patients, as you see here. And that's a pretty big delta. Now, to be absolutely sure that this is linked to NASH, we used 2 cohorts, a real cohort and a control cohort, and we investigated in Europe and the United States patients, also some patients, by the way, from Zurich. And again, we could show that patients that have actually a steatosis or NFLD etiology to liver cancer do respond worse. In our cohorts, even do not respond, but even have a worse response and a reduced overall survival that is even significant. And when you look in some of the patients, you cannot get many tissues. Upon treatment, you see hyperactivation of hepatocytes. You see a lot of P1 positive CD8 T cells within the tumor. So, and that's the American cohort where we can reproduce these data beautifully. So what I've shown you today is actually the following, that we believe that there are actually conceptually situations where the classical idea of that the presence of CD8 PD-1 T cells that are exhausted might be a good predictor for response to immunotherapy in the context of cancer is not the case when you have a fatty liver that has at the same time liver cancer. So this is a changing concept that we should think about when we talk about metabolic syndrome and obesity. I could show you that these hepatic CD8 PD-1 T cells are increased in NASH, in human and in mice. I didn't bore you with all the single cell sec data, and that it appears to be that these PD-1 positive CD8 T cells, when it comes to maybe anti-tumor surveillance, are dysfunctional. I didn't show you the data that one of the mechanisms, I know not very sexy, but that is what we have found, is TNF. So one of the signalings that is really important in triggering this immunotherapy-related increase in cancer incidence, at least in our mouse models, was TNF1 related. The downstream effects of this autoaggression of the T cells are regulated through the downregulation of a transcription factor called FOXO1 and this induction of this residential marker. And I've shown you then when performing this immunotherapy treatment, it increases NASH HCC incidence massively. I didn't show you in detail, but tumor size is increased and tumor number is increased as well. Immunotherapy antibody treatment changes the liver microenvironment. I've shown you these different things: inflammation, oncogenic signaling, and cell death. So that means immunotherapy NASH HCC, we now know this, is not more efficient than the classical standard of care. Some of the patients are even showing adverse effects in the context of immunotherapy. So what's the consequence? Number one, we will have to study what are the effects of neoadjuvant therapy in early stage HCC. There is a lot of investment, of course, now in this because you want to hit the tumor as early as possible. But what if this patient has a metabolic syndrome? In general, could it be that patients that have a metabolic syndrome have another tumor entity and are treated with immunotherapy might actually see adverse effects in the liver? And are there combinatorial therapies with which we could overcome resistance? I can tell you there are. We have already, not only us, other groups have very beautiful data on that you can overcome this CD8 T cell phenotype by changing the metabolic program in T cells, or for example, by changing the tumor microenvironment. So with this, I stop. I would like to thank you for your attention. This is the team that was involved. It's really a big effort to run these experiments. They take a very long time, and we have a lot of collaborators, and we have a lot of agencies that support us. And I would really like to highlight that in bold, these were the people that really pushed forward the projects that I've shown today, mainly Dominik Pfister, Mohsen Malemir, already also in collaboration with Achim Weber, Elena, Mira, and Suchira and Sandra. And I stop here, and I would like to thank you for your attention and ready to take questions.
Many thanks for this exciting talk and also for staying perfectly in time. We do have a couple of minutes for questions. One question, you've been mainly focusing obviously on the primary liver cancer. How would you expect that would affect secondary malignancies or metastatic disease? Assuming a patient having metastatic lung disease or metastatic colorectal, patients having lung and liver metastasis, and then does have a NASH syndrome. So how would it affect the efficacy of IO?
Has been published and correlates completely with our results. So at least in mouse models, the human patient cohorts are now being tested, but it's very clear that metastatic secondary liver cancer is very badly treated in the context of NASH. In contrast, if the mouse models at least did not have NASH, they were very nicely treated by immunotherapy if a tumor model was used that is responsive to the therapy, to AIO.
And that was a differential response between, for example, lung metastasis and liver metastasis. So the lung metastasis response, as you would predict it, and only the response in the liver would be kind of worse, as you would explain it.
Yes, I only refer to the secondary cancer. As far as the primary cancer is concerned, I am not aware of detailed studies that take into account at the moment the metabolic state of the patient, the quality of the metabolic syndrome, as well as I think the organ crosstalk between organs that are affected by the metabolic syndrome.
I'm looking into the chat. I don't see any further questions, so maybe a short one. I mean, one question which we get asked by almost all of our patients: can we kind of contribute to our treatment by dietary intervention? Could that open the door in these patients?
Yeah, we are doing studies in that direction. And you know, there are actually already published data, at least in the context of NASH HCC, that we are performing intermittent fasting regimens. So that means that the mice, and we are doing a clinical trial, actually starting it soon in Tübingen, where we fast the mice in a particular time frame. It's very important in which time frame, but the overall caloric intake is not changed. So that means that our mice eat the same amount of kilocalories over the week, but they have different time frames in which they actually do not eat at all. And what is very striking when you look into the liver, but also when you look into the immune system, is that within hours, even though there is pathology present, there is a reprogramming of metabolic cues in hepatocytes, but also immune cells. And it is tempting to speculate in the context of NASH HCC that immunotherapy is more efficient, but for kinase inhibitors and for other therapies, it has already been published just recently that intermittent fasting in the context of liver cancer can increase the efficacy of treatment.
That is in the context of NASH or also in patients having a virus induced?
This is in the context of NASH, so of non-viral liver cancer induced by diet.
Okay, are there any further questions? If not, thanks for an exciting talk. Thanks for staying with us and contributing to the discussion later on. And with that, I would like to introduce the second speaker of the second kind of part of the symposium, Professor Ping-Shi Ho. He has been trained at the National Taiwan University, then spent some time in Minnesota. And now we're here. Okay, so.
Can you see the full screen?
Yes, all good.
Okay, perfect. So these are my disclosures. And as we know, immune checkpoint blockade has completely changed the landscape of oncology treatments today. But the problem is that only half of cancer patients are eligible for immune checkpoint blockade therapies, and that indeed only a minority of them who are eligible will actually respond to these treatments. And unfortunately, clinicians are still struggling to identify predictive signatures in the tumor microenvironment. So one of the hallmarks probably is the high T-cell infiltration that is found in certain melanoma or lung cancer patients or kidney cancer patients, which is usually accompanied by other signatures in the TME, like we discussed before with Ping-Shi, like interferon gamma signatures or expression of PD-1 on CD8 positive cells. So this is a sort of hallmark or dominant attribute of responder patients. However, today we go a little bit deeper in biology, asking what are the characteristics of these CD8 cells infiltrating the tumor microenvironment. And one of the fundamental things to understand is that when a T cell is stimulated, the TCR stimulation by viral or tumor antigens will initially stimulate a population of naive T cells, which will have a special transcriptional program exemplified in this cartoon. These cells usually have a transcriptional factor called TCF. They are TCF positive. They will become effector T cells. They will downregulate TCF, and they will upregulate other transcriptional factors like BLIN1, TBET. They will become effector T cells. They will proliferate, secrete cytokines like interferon gamma, TNF alpha. And with that, they increased the surface expression of PD-1 as well as other co-inhibitory receptors like TIM3. This is what we call today in oncology the fully exhausted T cells. These T cells usually have impaired effector function. They have increased of several co-inhibitory receptors, and they usually lack memory formation. There are other transcriptional factors, like, for example, TOX, that was recently described as a more committed or just not reversible exhausted program on these cells. But this was put a little bit up and down these last years because we discovered that these T cells actually come from a pool that is called precursor exhausted T cells. The precursor exhausted, they actually have TCF, they are TCF1 positive. They also have PD-1 on their surface, but they expressed on their surface other markers like CSCR5, markers of trafficking to the lymph node. What the difference is that these precursor exhausted, they can self-renew. They are the progenitors of the exhausted T cells, and these ones are the hallmarks of high response to immune checkpoint blockade. So with this in mind, we need to think that these cells need to get also antigens from very highly specialized antigen-presenting cells. And through single-cell RNA sequencing, today we know that the antigen-presenting cells or dendritic cells, they come in different flavors. For example, in this cartoon, courtesy from Michael Pité, the DC1 cells, we know that they are highly specialized in presenting antigen. They are driven by a transcriptional factor in the mouse called BATO3. The DC2 cells, they are highly specialized in co-stimulating T cells. They particularly stimulate CD4 T cells, et cetera, et cetera. So when we, the beauty of this, understanding these systems is that now we can understand that for a given treatment in oncology to work, we should probably prolong the status of precursor exhausted T cells or locked the passage of these cells to an exhausted phenotype. And this is true for whatever treatment in oncology we use, particularly not only immune checkpoints, but also radiation therapy. What it is important to know that these programs were described in hot tumors, but the problem here is that the cold tumors are the ones that do not respond to immune checkpoint blockade. So how to overcome this primary resistance of cold tumors to immune checkpoint inhibitors? And we know that radiation therapy is one of the most effective tools, not only for killing cancer cells, but also for inflaming the tumor microenvironment. As first demonstrated by Laurent Vogel and Guido Kremer, who discovered that radiation damaged tumor cells actually activate APCs via the release of damage-associated molecular patterns or alarmins, which stimulate cytolytic CD8 T cells. So this is called in situ vaccination. And the most compelling evidence of the in situ vaccination effect of radiotherapy is the presence of abscopal effects, which means the disappearance of metastases outside the irradiated area. As seen in this patient that was treated at the CHUV a few years ago, he had an infiltrated hot tumor, plenty of CD8s in the tumor microenvironment. It was a mesothelioma, plenty of metastatic disease. He progressed on anti-PD-1 therapy, and while progressing, he received a large field of high-dose irradiation, around 30 gray, 10 times 3. And after the radiation, a few weeks after, we could note an important regression of all metastatic deposits, those that were irradiated and those that were not irradiated. The problem is that the abscopal effect remains rare, and randomized clinical trials were not able to capture this, as you can see in this trial recently published in JCO in head and neck cancer patients. So this raises the question that we probably irradiate a few metastases based on standards of care using SBRT. The remaining metastases probably are not reprogrammed by the SBRT that we deliver to one or two of them. And there are other factors in the tumor microenvironment that probably will need to be tackled if we want to observe more abscopal effects. So we have been working on this model for several years, hypothesizing that low-dose irradiation delivered to large treatment volumes would be feasible and could reprogram the tumor microenvironment by upregulating key chemokines, cytokines that are involved in the recruitment of effector T cells, effectively converting the tumor into an inflamed tissue. And we also, we were thrilled to see some preclinical work where, for example, radiation increased the expression of cell surface intracellular radiation molecules like ICAM on endothelial cells, favoring the passage of T cells to the tumor microenvironment. So we thought to investigate this hypothesis in models, murine models of ovarian cancer, a disease that so far has eluded immune checkpoint blockade combinations. And it's a disease that is, in general, half of the patients do not have T cells in the tumor microenvironment. They have low tumor mutational burden. And it has to be recognized that radiation was used in the past for ovarian cancer, but it was abandoned because the large fields that we used were extremely toxic. So we cannot perform large fields or large volumes of SBRT in this kind of disseminated abdominal disease. That's why we started testing this low-dose irradiation in models of ovarian cancer, where we indeed irradiated the whole abdominal cavity of the animal. And initially we performed a kinetic analysis to see what's going on in the microenvironment, for example, 24 hours, 5 days, 7 days, after low-dose radiation. We investigated 3 doses, 0.5, 1 gray, or 2 gray, and we observed increased lymphocyte infiltration, CD8, CD4s, also CD11b positive cells in the tumor microenvironment 7 days after delivering 1 gray. The CD8 Treg ratio was better in 1 gray, and we corroborated our findings by immunohistochemistry and flow cytometry, as well as unbiased analysis, RNA sequencing. So with this in mind, we asked the question if 1 gray, because 1 gray is a very small dose for those who run the clinics today, it's something that we wouldn't even use in clinical practice. So we asked whether 1 gray was sufficient to reprogram the tumor microenvironment, or if cyclic administrations of 1 gray were required to maintain the desired immune reprogramming. So we administered 1 gray in 3 weekly cycles, and we examined the digested tumors by flow cytometry just before the next cycle was administered. And as you can see here, you observe T-cell infiltration, CD4, CD8 cells, also myeloid cells, probably dendritic cells because they express MHC class 2. Immediately after the cycle 1, these cells decrease in the microenvironment before the application of the cycle 2, a week apart. And then when you administer the 3rd cycle, they actually increase again. So this was a nice observation. And we also saw by unbiased analysis that certain chemokines like CXCL9, CXCL10 were upregulated in the tumor microenvironment upon 1 gray, justifying the increased T-cell infiltration that we were observing. And indeed, this T-cell infiltration was dependent on type 1 interferon and interferon gamma, because when we depleted the animals of these interferon gamma and type 1 interferon, we totally lost the immune infiltration. Through an unbiased analysis of the tumor microenvironment, we also discovered that radiation upregulated druggable immune targets like PD-1, like CTLA-4, like CD40. So we thought to develop a combinatorial treatment strategy addressing these immune targets that were upregulated by low-dose radiation. Thus, we administered immune checkpoint blockade targeting anti-PD-1, anti-CTLA-4, and CD40 agonists in combination with cyclophosphamide in order to deplete Tregs. So the whole microenvironment, the myeloid compartment and the T cells, plus the Tregs would be targeted. And this combination was, we added 1 gray radiation. We call this combo racim, and we administered racim in the animals once a week in 3 cycles. As you can see here, racim induced an important therapeutic benefit in the animals. We observed actually 80% of the animals, or 87%, they respond to the therapy. And a few animals represented here in this swimmer's plot, waterfall plot, they were actually in complete response. And this translated in a significant overall survival advantage that was observed with the combination therapy. So racine also increased T-cell infiltration in the tumor microenvironment by immunohistochemistry, and this T-cell infiltration was totally dependent on low-dose radiation. So we asked the question if the whole components of the racine cocktail were required for tumor control, and that was the case. When we delivered racine without anti-PD-1 or without anti-CTLA-4, we lost overall survival, and underscoring the key role of T cells for animal cured, the reason was that we totally lost the CD4 cells or the CD8 cells when PD-1 or CTLA-4 were not administered. And the same happened when CD40 was omitted from the cocktail. So we lost overall survival, and actually we obtained a pattern of M2 macrophages in the tumor microenvironment with much less CD11B, CD11C, MHC class 2 positive, probably dendritic cells in the TME. Cyclophosphamide, indeed, when we didn't administer it, was detrimental because we observed much more Tregs in the tumor microenvironment. So we performed an unbiased analysis and a question, who were these populations of T cells and why qualitatively they were so important for the racine responses. So the Ts from tumors treated with racine were highly enriched in activated effector T cell populations, which were assigned largely to the exhausted and progenitor exhausted phenotype that I previously presented. There were also Tregs, normal, because when you have T cell activation, there has to be Treg, but the Th1 Treg ratio was much more favorable in racine than in SIM or control. So these new populations have been largely described in the CD8 compartment, but to our surprise, the racine induced this population of precursor exhausted cells in the CD4 compartment. And they were highly activated because they expressed interferon gamma, TNF-alpha, and perforin. And as you can see here, these are the genes that usually describe these populations like TCF, TOX, PD-1, LAG3, or TIM3. CD4s and CD8s were essential for tumor control, and we depleted the animals of CD4s or CD8 cells, and we totally lost the overall survival advantage of racine. The TCR sequencing also showed that the same clonotypes were present in the populations of precursor exhausted or exhausted T cells. So meaning that probably there is an interchange of these populations that happens along treatment. And it was the same in CD4s and CD8 cells. The important thing is that the myeloid compartment was critical also for tumor control. So we also characterized by single cell RNA sequencing the myeloid compartment. And to our surprise, dendritic cells type 1, the DC1, which are those that in the mouse are driven by BATF3 transcriptional factor, they were key for responses to racine, because when we treated the animals in the context of BATF3 knockout, we totally lost the therapeutic benefit. And these cells were fully, they fully expressed MHC class 1 on their surface. But they were not alone. There were also DC2s, and the DC2s expressed all the markers of co-stimulation like CD40, CD80, CD70, CD86. So we asked the question, what this population of DC1 and DC2 have that is so juicy and so important for the T cells to be primed. So by single cell RNA seq, we discovered that a gene called RAE1 that was previously described in the years 2000 by Gasser and collaborators to be present in the tumor. Actually, in our model, it was present on the myeloid compartment on the DC1 and DC2 population. So we corroborated RAE presence by immunohistochemistry, and it clustered or co-localized very close in contact with CD11B positive cells. So certainly the next question was where the ligand of RAE is localized, and not surprisingly, we found NKG2D, the ligand of RAE, here represented by KLRK1 gene in the CD4 compartment, as well as in the CD8 compartment. These cells, we sorted them by FACS, and we saw that these cells were TCF1 negative, PD1 positive, CD8 or CD4 positive cells expressing NKG2D. They were highly proliferative. So this NKG2D probably defines a population of canonically exhausted T cells that are able to collaborate with RAE positive dendritic cells. NKG2D blockade was essential for tumor control by racine. So with this in mind, we went to treat patients with a similar combination. So we designed a clinical trial that we call RACINE. And RACINE stands for radiation, cyclophosphamide, nivolumab, and ipilimumab. We could not obtain CD40 agonists at that time because there were issues with toxicities with CD40s. So we tried to replace CD40 by aspirin, which is known to also reprogram the myeloid compartment. We delivered 4 cycles of racine, but there was a cycle 0. And the cycle 0 was actually done on purpose, where we deliver radiation alone. The idea was to take a biopsy before and after radiotherapy in order to corroborate that radiation at low doses was reprogramming the tumor microenvironment. We selected patients that were TIL negative. So these were immune desert patients. They had to have less than 5 CD8 cells in the tumor microenvironment analyzed by our pathologists. So this is one of the vignettes, responses to racine, an ovarian cancer patient. She had intra-abdominal and extra-abdominal disease. We targeted all what we could. And there was more than that. I mean, I just put one picture here, but we did much more radiation in the middle of the thorax and also vertebrae that were affected. And you can see here the impressive response that this patient had 16 weeks post-treatment. Corroborating this, there is an important decrease in the CA125 tumor marker. However, This lady progressed a few weeks after receiving raceme. And when we were analyzing the study, we sit down with the radiologist to see where the sites of progression were. So I actually put my TPS program on radiotherapy, and I showed the radiologist the areas that I irradiated. In most of the patients that were published in this paper, all the areas where they recurred were the areas that did not receive the 1 gray irradiation, highlighting that probably all the metastatic deposits need to be reprogrammed in order to have better responses to immune checkpoint blockade. And this is this patient actually, she didn't have T cells. This is 1 cell in the tumor microenvironment, and she was highly enriched after only 1 gray irradiation. There were CD4s and CD8 cells infiltrating the tumor microenvironment. Responder patients had a signature of type 1 interferon, more immune activation, more antigen presentation, and innate immune activation. The non-responders actually have M2 macrophages, T cell exhaustion, and characteristics of epithelial to mesenchymal transition. We corroborated those findings also by nanostring geomics, where we saw, for example, in mature dendritic cells in the non-responder patients, M2 macrophages, and the responders have actually a Th1, T helper 1 immune response. So most of these signatures in the non-responders, the M2 macrophages, they were actually localized in the tumor stroma. We could dichotomize this by nanostring geomics, which allows us to see, to tackle the cells that are localized either in the tumor nest or in the tumor stroma, while the responders patients have mainly T cells that localized inside the tumors. So how we are moving this forward? Well, we want to randomize this treatment. We need to get adapted to the standard of care. So in platinum-sensitive ovarian cancer, we are performing a phase 2 randomized trial where carboplatin PLD, a standard of care, will be administered either alone or in combination with a CD40 agonist or the addition of CD40 agonist plus low-dose radiotherapy. The primary endpoint is pathologic complete response. These patients usually can undergo surgery. So we are going to analyze also the tissue that we get before and after combinatorial therapy. Mansoor Raza Mirza is the PI. He's the president of ENGOT and the NSGO group. And Narda Denga from our group is going to be the key leader for analyzing tumor biopsies. So my colleagues in radiation oncology, I'm sure asked the question, but why the patients do not respond when we deliver SBRT, and why we don't see more abscopal effects? So we have highlighted these issues in a recent paper that we just got published this week. I think abscopal effects are uncommon in cancer patients, and that the high dose irradiation probably increases T cell infiltration, but it also increases some immune suppression in the tumor microenvironment. And our paper was published, but actually 2 other papers were published in very close dates, and they corroborated our findings. In one of those papers, actually Patel from Zachary Morris group, he delivered low-dose radionuclide therapy with 2.5 gray to the delivered systemically. And in another paper, the group from James Welch delivered actually 1 gray to all visible metastases in a lung cancer mouse model and also in lung cancer patients. What they did, these 2 papers, is they combined low-dose irradiation with SBRT, and they could demonstrate that actually these treatments, low-dose plus high-dose plus immune checkpoint, do better than single treatment alone and do better than low-dose radiation plus immune checkpoint combined. So there is hope in the field that we probably can continue investigating this and come up with responses for these patients, and maybe one day we can see more abscopal effects. So with that, I would like to thank my colleagues from Lausanne, the Kukos group, a huge amount of people that work in this publication, and I would like to thank you for your attention.
Many thanks, Fernanda, for an excellent talk. Thanks also for staying perfectly in time. As always, if you would have questions, please use the chat functionality to do so. And maybe I can ask, I mean, we have been focusing on many centers and many studies have been focusing on high dose radiation to kind of evoke and enhance the immune system. You're now focusing on low dose irradiation. Simultaneously, we have actually seen in radiation oncology a massive increase in low-dose radiation by the shift from conventional 3D radiation to IMRT. Have you looked at historical cohorts, whether you could actually see changes of efficacy of immunotherapy and maybe also changes of survival of patients by this technology kind of shift, which also kind of was involving this high dose versus low dose distribution?
Yeah, we have checked a few patients in our institution that had quite beautiful responses. There was one abscopal effect, but this was the only one. And the question is it when you use other kind of technology that is not so punctual, maybe you are just distributing low dose all around the body, and this is what it makes the tumors respond. We see decrease in tumor size in areas that receive low dose. We also discussed this with James Welch, who actually published a small series of patients where he observed the same. So it's possible that when you actually use different technology, you just distribute some dose. And when I say some dose, it's very heterogeneous dose, so we cannot even know how much it is. It can be 0.5 gray, even less. It can be maybe 1 gray, and that this induces some kind of immune reprogramming.
Selma, you're raising your hand, please.
Yes, very nice talk and very interesting data. I immediately have a question about what do you know, or what is your observation about different solid tumors? Because we have the impression if we compare melanoma and, for example, Merkel cell carcinoma, then in melanoma, the kind of immunosensitization by radiation is not so nicely working, or maybe not at all working. Whereas in Merkel cell carcinoma, there's a very nice synergy. So do you also share this observation, or do you have maybe experience with other solid cancers?
Absolutely. I mean, in the clinical trial, there were no melanomas because melanomas usually are immune infiltrated. So most of our patients were prostate cancers, ovarian cancers, gallbladder cancer, colorectal cancer, and 3 patients had beautiful responses. One was a prostate cancer patient. He actually had an almost complete PSMA response. All these patients, prostate patients, we tried to follow them with PSMA PET to corroborate that there was some activity of the treatment. There were 2 ovarian cancer patients with beautiful response. One of them is published in this paper, and the second one will be published pretty soon because the trial just recently finished, so we are analyzing the data still. And the other patient was a gallbladder cancer patient who actually, it's published in the paper, and the tumor completely shrunk, and I think it was 14 weeks after starting therapy. We looked into tumor mutational burden in these patients. They had very, very few somatic mutations, so we cannot attribute that responses to that. And they were PD-L1 negative. And when I say that, I would say there is an interesting randomized trial that I'm sure Matthias knows very well, because it's the trial published in JAMA Oncology by Tellen, where he randomized the patients to pembrolizumab SBRT, non-small cell lung cancer patients, pembrolizumab SBRT versus pembrolizumab alone. And he observed that there was a trend in PFS that favored pembrolizumab and SBRT, and that trend was observed in patients that were PD-L1 negative. So I'm raising here the question that maybe this sort of massive irradiation can probably just upregulate molecules in the microenvironment of those patients that are not so favorable for immune checkpoint blockade, as you mentioned. For example, outside the melanomas or the lung cancers that are PD-1 positive or high tumor mutational burden.
Oh, very interesting, thank you.
Okay, I don't see any further questions in the chat. Also seeing that we are kind of only 4 minutes, but still 4 minutes overdue and over time. I would like to kind of end the symposium, and first of all would like to thank all speakers, Fernanda and everyone, for giving excellent talks. It was very interesting. It was fascinating to see the developments. Also, thanks for aligning your talks very well. We hope to see you soon physically. It was the 6th Immuno-Oncology Symposium here in Zurich, and we want to make that an even longer tradition. So we will continue in the upcoming years, and hopefully we'll have a physical interaction and also have some fun afterwards with some good dinner and some interaction. Many thanks also to Silke for organizing the event. It was all perfect again. So a big applause to you, Silke, for organizing and kind of doing the heavy workload for the technology in the background. If everything works, it's kind of normal. If anything goes wrong, it's a pity, but it was all perfect. So thanks a lot. And final thanks obviously goes to all our participants for staying that long and for staying also active. Many thanks. Hopefully seeing you physically soon. Have a good evening and bye everyone.
Bye-bye. Thank you.
Bye.
Bye. Thank you. Bye.
Also vielen Dank nochmal, war toll gewesen.
Danke. Ciao.
Schönen Abend. Ciao.
Tschüss.